Coming on to hypomagnesemia in CKD and post-kidney transplant, I've just kept the slide green just to refresh our memory that magnesium is the core central atom of chlorophyll, the green pigment molecule. We do check magnesium levels when we suspect, but for us, magnesium is often a forgotten ion, but it is not that forgotten for media or general population. Before going into the topic per se, let's just see a viral clip from a popular Malayalam actor. So we will come on to this. So magnesium is the fourth most abundant element in human body, the second most abundant cation in the and its normal concentration is up to from 1.7 to 2.1 milligram per deciliter. Of around 25 gram of total body magnesium, only 1%, less than 1% is in the plasma, and the ionized form is around 55%. So coming on to the absorption, magnesium is predominantly absorbed from the distal small intestine, mainly through the passive paracellular absorption pathway, and 10 to 20% absorption occurs via the TPR M6 M7 path channel also. And the renal handling of magnesium, 15 to 20% of absorption occurs from proximal convoluted tubule and up to 65% from thick ascending limb, unlike other cations, and 15% from distal convoluted tubule. In thick ascending limb, the main absorption occurs again via paracellular pathway with the sodium potassium 2-chloride transporter and the ROMK channel, creating a lumen positive electrochemical gradient, causing magnesium drive across the paracellular pathway. And in the distal convoluted tubule, there is TRP M6 causing the active transport via the transcellular pathway, which is regulated by epidermal growth factor and estrogen. So the physiological role of magnesium, it's a cofactor for about 600 enzymes, and it is needed for the activation of ATP, nucleic acid stabilization. It affects the membrane potential of cells and excitable tissues. And in distal nephron, it is important for potassium homeostasis, and it has a significant role in regulating parathyroid hormone secretion by its indirect effect on vitamin D metabolism. So hypomagnesemia is a serum concentration less than 1.7 milligram per deciliter. The prevalence of hypomagnesemia in general population is around 2 to 5%, and it varies when specific groups such as elderly, hospitalized, or ICU patients are taken. And in chronic kidney disease, the prevalence of hypomagnesemia, even with very low GFR, can extend up to 20 to 30%. And in post-kidney transplant, according to the timeline, the prevalence varies, and in the early post-transplant period, it can go up to 90%, and in 3 months to 1 year, 30 to 60%, and more than 1 year, 10 to 30% patients can have hypomagnesemia.
Sir, when should we suspect hypomagnesemia, and what are your thoughts on routine magnesium monitoring?
I think we have to look at it from 2 point of view, two different contexts. One is in general practice, when not necessarily related to nephrology. So here I would say in Pondicherry there is a very peculiar situation. So there are three situations where we routinely check magnesium. Vidhya must be quite familiar with that. One, we have a very high frequency of hypokalemic paralysis presenting. Okay, over the years in nephrology department itself, we have collected a case series of more than 200 patients, which I think is probably the largest case series, and we have people, a good number of them, having what we call the Gentleman phenotype. So they have hypomagnesemia, they have hypocalciuria, all those things are there, right? So we have a high incidence of hypokalemia. So that is one situation where we will routinely check for hypomagnesemia. The other is again in the post-transplant setting. We actually had presented a paper in ISOT 2023, I think, reporting the frequency of dysalacrytemias in the immediate post-transplant period. Hypokalemia, hypophosphatemia, hypomagnesemia is almost 70-80%. So that is one situation. As of now, follow-up to that, we have actually done a RCT comparing plasmalite with our normal fluid regimen, and in that study, the last person is being randomized next week. The prevalence of the incidence of hypomagnesemia post-transplant in the first 48 hours is 90%. So that is one pre-transplant, and in the post-transplant, we actually monitor it every day. That is another context where we frequently, routinely monitor magnesium. The other situation I think we should do, which is not necessarily related to kidney is when we have seizures. That also I learned the hard way, where during my MD time in Trivandrum, there was a patient with status epilepticus, and on a hunch of this thing, I sent off a magnesium level, and the patient had severe hypomagnesemia, and with correction of magnesium, the seizures got controlled. So I would say arrhythmia and seizures are especially when unexplained or difficult to control, are situations where I would check magnesium even now. In nephrology, yes, and to the poll, I think personally, from our experience, I would think the most common reason is poor intake. That is why we see it in CKD patients, because there are dietary restrictions imposed. Our dialysis patients are malnourished, and that is, I think, one reason. Even before transplant, we are finding they are hypomagnesemia. So there are some peculiar situations, unfortunately, here where we routinely check, but in CKD, I can otherwise say that we don't do it routinely in all CKD patients, and it is not recommended also. Yeah, but there are some situations in our practice where we routinely do. That is from our own experience.
Going into the causes of hypomagnesemia, it can be divided as non-renal magnesium wasting or renal magnesium wasting. Under the non-renal magnesium wasting comes the gastrointestinal causes like poor intake, decreased absorption or increased loss, and intracellular shifting or sequestration. And the renal magnesium wasting causes include the increased GFR or issues with the parts of kidney tubule, proximal thick ascending limb or distal convoluted tubule. So dietary intake, isolated dietary intake alone in a normal person causing hypomagnesemia is not usual, because kidneys can conserve magnesium in a very efficient way, where fractional excretion of magnesium can go up to less than 1%. But when it comes as a multifactorial cause, yes, dietary intake is a significant cause, and especially as Sir mentioned, in CKD, dietary intake can be a cause. And in diet, high levels of phytic acid, oxalic acid, high calcium, and excess fat can inhibit the absorption. And the use of proton pump inhibitors, especially in a chronic and high dose, can reduce the TRPM6 activity of intestine, where the acidic milieu is disturbed, causing decreased activity, causing decreased absorption, and resulting in hypomagnesemia. So this is just roughly what we have discussed.
This time it's a clinical scenario. So there's a 65-year-old patient on chronic loop diuretics and proton pump inhibitors. This patient presents with muscle cramps, refractory hypokalemia. Potassium is 2.8 despite replacement, and she has QT prolongation. Serum magnesium was found to be 1 milligram per deciliter. So in this case, what is your first priority in management?
Yeah, I completely agree that without correcting magnesium, the high potassium will not get corrected in this population. So that is one reason for resistant hypokalemia. So I agree that is the first thing we should be doing. Stopping PPA and all will help in the long term. Yes, again, for the very unique situation where we see often this hypokalemia, which is due to various combination of, we have done multiple MD theses and DM dissertation on this particular topic, at least 3 over last 10 years. Honestly, I think it is a combination of multiple factors, and this is not infrequent, that is in our setting, but I can still, having worked in multiple places, I think what we are seeing is very unique to this place. I don't think that is very common in either in Kerala or in northern part of the country. But when you have hypokalemia, when the cause is not very evident, or even when you have an evident cause like diuretics or something, and if it is not getting corrected promptly, I think we should always check magnesium. Like in the other case I was telling, when you have seizures and it's difficult to control, you don't have an obvious reason, then we should be checking not only calcium but magnesium as well, and correction of hypomagnesemia will help in that situation.
As we have already discussed, refractory hypokalemia is a scenario where all of us will universally check magnesium levels. So we'll just see which are the specific entities or situations where chronic kidney disease patient should be checked for magnesium levels. So CKD patient with refractory hypokalemia, how does this happen? Magnesium regulates the activity of ROMK channel, and this ROMK channel on the apical surface of the distal nephron is the one which causes a back leak of potassium. The intracellular magnesium levels or intracellular magnesium is important in blocking this ROMK channel O and preventing the potassium efflux. So when there is hypomagnesemia, it will cause a potassium efflux resulting in hypokalemia. So after correcting magnesium only, we'll be able to perfectly correct the hypokalemia. So other possible mechanisms include dependence of sodium potassium ATPase, sodium potassium co-transporter, and other transporter process on the magnesium ion. So another situation is hypocalcemia disproportionate to the stage of CKD. Hypocalcemia without appropriate elevation in parathormone levels. The magnesium deficiency can cause a functional hypoparathyroidism, where hypocalcemia cannot be treated with correcting calcium or vitamin D alone. So the mechanisms include impaired secretion of PTH, end organ resistance of PTH, increase in metabolism of PTH, or decrease in 1,25-dihydroxy vitamin D. And magnesium therapy is necessary for correction of calcium levels in these situations. And it is interesting to note that mild hypomagnesemia stimulates PTH, but very severe deficiency causes paradoxical suppression of PTH.
Sir, in your practice, how often do you see drug-induced hypomagnesemia?
Drug-induced, I don't think most of the cases we do use are drug-induced, because one reason is the prescription of proton pump inhibitors in our OPD practice is very less. We largely tend to not to prescribe proton pump inhibitors. It's mostly S2 blockers because famotidine is available. And I wanted to add a point in addition to what Dr. Vidhya presented. One of the main mechanism by which PPI produce hypomagnesemia is by poor absorption, even though there is a component of renal loss also, but the predominant component, so that is obviously a wrong answer in this. So all of the above is not correct. The predominant mechanism is poor absorption from the GI tract because of, you can check the mechanism. I think among the three, thiazide diuretic is the most common, but again, as a nephrologist, our use of thiazide diuretics is very less. We tend to use more loop diuretics. I believe I have not checked literature on that. Between loop diuretic and thiazide diuretics, I think thiazide diuretics are more likely to produce hypomagnesemia. Specifically answering your question, Dr. Jason, drug-induced, I think, is infrequent in our practice, what we are seeing. I think most of the hypomagnesemia we see are not per se related to drug. I'll be reluctant to attribute them to drugs like PPIs or diuretics. Our situation, I think, is different. I believe, I don't have proof, but I believe it is a combination of poor intake. We have documented potassium intake, we have studied. Magnesium intake, we have not studied. But it's true that they are malnourished generally, and I think that is a major predisposing factor. There may be other things like some renal wasting and chronic diuretic intake in some of.
Decreases the TRMP M6 activity and decreases the intestinal absorption, causing hypomagnesemia. And loop diuretic diminishes the epithelial voltage gradient required for the magnesium paracellular transport. And thiazide also decreases the TRP M6 in the DCT. So loop diuretic can cause some more magnesium loss than thiazide, but it is thiazide that causes a more persistent hypomagnesemia when compared to loop diuretic. PPIs can also cause a severe and chronic hypomagnesemia, but a combination of PPI with the thiazide is the worst hypomagnesemia that can occur out of these. So another situation is proteinuric CKD, diabetic nephropathy, nephrotic range proteinuria. The tubular injury from proteinuria and impaired distal magnesium reabsorption can cause hypomagnesemia in this group of patients. And there are some studies, these are some of the studies which have looked into the effect of proteinuria and hypomagnesemia, and they have shown that proteinuria, the grade of proteinuria was related to the hypomagnesemia levels, and those patients had more fractional excretion of magnesium with increasing proteinuria levels. Another situation is diabetic kidney disease with poor glycemic control, where hyperglycemia can cause osmotic diuresis, which wash out the epithelial voltage gradient, again causing magnesium wasting. And also hypomagnesemia worsens the insulin resistance. And these are two studies from Kerala itself, one from South Kerala and one from North Kerala, which have looked into the incidence or prevalence of hypomagnesemia in diabetic patients. And both of the studies showed around 15% and 19% of hypomagnesemia in diabetes. And in these studies, 60% of patients had diabetic kidney disease ranging from microalbuminuria to diabetic to CKD. So other situations in CKD where hypomagnesemia may be important is chronic diarrhea, malabsorption, malnourished or elderly, and patients with neuromuscular symptoms like muscle cramps, tremors, weakness, and of course arrhythmias, and CKD with tubular dysfunctions where polyuria, metabolic alkalosis is present. And above these, in post-kidney transplant hypomagnesemia. Early post-operative dyselectrolytemia is an important cause of hypomagnesemia. It can be multifactorial because of high urine output causing recovery diuresis where hypomagnesemia is usual and can go up to 90% and is present with the pan-dyselectrolytemia. And along with that, calcineurin inhibitor use is a contributing factor. So CNI-induced hypomagnesemia, tacrolimus and cyclosporin can downregulate TRPM6 and also epidermal growth factor, which has a regulatory effect on TRPM6. And tacrolimus, when compared to cyclosporin, causes a greater extent of hypomagnesemia. So these are again some studies showing tacrolimus-associated hypomagnesemia, where 43% of patients had hypomagnesemia. This was not in the early post-transplant period, and they had significantly elevated fractional excretion of magnesium, and magnesium levels inversely correlated with the tacrolimus level and creatinine clearance. There's another study where 120 kidney transplant patients were studied in the first month, and the incidence was 90%, but this is irrespective of the CNI levels. And a patient on CNI with new hyperglycemia. Magnesium is required for insulin receptor tyrosine kinase activity and downstream signaling. And insulin resistance and impaired insulin secretion occurs in hypomagnesemia. And added on that, CNIs being diabetogenic can also cause hypomagnesemia. So here, hypomagnesemia, insulin secretion, and action in patients without diabetes was studied after 1 year of kidney transplantation, and it was shown that patients with lower plasma magnesium levels had a higher fasting plasma glucose, and there was no difference in insulin sensitivity indexes or dynamic insulin measurements. And this was an RCT where 54 patients were taken within 2 weeks of post-transplant, and patients with hypomagnesemia were randomized to 450 mg magnesium oxide up to 3 times daily or no treatment, and were reassessed at 3 months, where it was seen that magnesium supplements modestly improved the fasting glycemia levels without effect on insulin resistance. Another condition is post-transplant infections, where infection-related tubular dysfunction can occur, reducing the absorption and increasing the renal wasting. Also, post-transplant diarrhea, increasing the GI loss, and patients can have increased tacrolimus levels during infections, which can again downregulate the TRPM6 pathway. And also, treatment with aminoglycoside, amphotericin B, foscarnet, or ganciclovir can be independent risk factors for hypomagnesemia. So these are some situations where we should be checking magnesium levels in CKD and post-transplant patients. So in first 3 months, polyuria, tubular recovery, and CNIs. 3 months to 1 year, CNI infections and diarrhea contribute to hypomagnesemia, and in more than 1 year, use of PPI, diabetes, chronic graft dysfunction leads on to hypomagnesemia. So clinical manifestation, mild hypomagnesemia is usually asymptomatic, and moderate to severe can cause neuromuscular features, cardiac features, especially arrhythmias, and refractory hypokalemia, hypocalcemia. So if there is hypocalcemia, we have to assess the fractional excretion of magnesium or 24-hour urinary magnesium, and to see whether it is renal magnesium wasting or non-renal magnesium wasting, and then assess the causes accordingly. So treatment, patients with severe symptoms should receive IV magnesium with continuous cardiac monitoring. If the patients are hemodynamically unstable, 1 to 2 gram of magnesium sulfate, IV bolus can be given initially over 15 minutes. And if the symptoms persist, a repeat bolus can be administered. Hemodynamically stable patients with severe symptomatic hypomagnesemia can be given up to 2 grams of magnesium sulfate over 5 to 60 minutes, followed by an infusion, that is 4 to 8 gram of magnesium sulfate over next 12 to 24 hours. And those should be repeated after repeat magnesium levels as necessary to maintain the concentration above 1 milligram per deciliter. And in normomagnesiemic patient with hypocalcemia, to restore the body magnesium levels, it has been suggested to repeat this dose daily for 3 to 5 days. And when dealing with patients with low GFR, reduce the IV magnesium dose by 50% and closely monitor the magnesium concentration. And coming under the oral magnesium, the typical dose in patients with normal kidney function is 240 to 1000 milligram of elemental magnesium in divided doses. And there are various forms of magnesium, organic and inorganic, available. And the commonly used one, magnesium oxide, has a high elemental magnesium, but the bioavailability of this is very low as to 4%. And the tolerability causing diarrhea is also there. And other forms include carbonate, hydroxide, citrate, lactate. And magnesium carbonate is commonly used as a laxative and used for antacid effects. And magnesium citrate is laxative. And magnesium phosphates have been used in fibromyalgia, prevention of heart disease, bone health, and even regulation of cholesterol levels. Magnesium oxide, as we have discussed, has high concentration but low bioavailability. And it is interesting to see an magnesium orotate as a molecule which has low concentration, but the bioavailability goes up to 40%. And there is a better intracellular uptake, as this orotic acid is capable of transporting magnesium through the cell. So, correction of any other underlying disease in patients with hypomagnesemia due to renal magnesium wasting, they may benefit from addition of potassium sparing diuretics such as amiloride or triamterene, which can decrease the magnesium excretion by increasing its reabsorption in the distal nephron. And is it just for symptomatic management? There are some other benefits of correcting magnesium also. The calcium and phosphate molecules. Magnesium inhibits the maturation of calci-protein particles. Calcium and phosphate clusters or supersaturation occurs in blood, and it binds to fettuin to prevent crystallization. This forms the calci-protein particles. The CPP1 in the hyperphosphatemia, in the presence of hyperphosphatemia, can mature to CPP2, which is the culprit causing vascular calcification, inflammation, and kidney injury. So adequate magnesium levels have an inhibitory effect on the maturation of CPP1 to CPP2. So thereby decreasing a vascular smooth muscle calcification, inflammation, and oxidative stress. The other thing is hypomagnesemia, decreased nitric oxide synthesis. It increases the CRP interleukin 1 levels and enhance platelet aggregability. And all these factors exacerbate hypertension through increased vascular stiffness, and this can worsen the cardiovascular status. So this has significance in both CKD and post-transplant patients. And there has been cohort studies done in Japanese dialysis registry, where it was shown that lower pre-dialysis serum magnesium levels were associated with a higher risk of 1-year mortality. And patients who had mild hypermagnesemia had the best outcome. And also, magnesium is a cofactor in natural killer cell and T cell reactivity. So hypomagnesemia may modify the course of infections, which is particularly important in the post-transplant scenario. So this was a study done in post-kidney transplant patients. 376 kidney transplant recipients were taken, and 60% of KTs within 3 months of post-transplant had hypomagnesemia. And it was shown that magnesium deficiency is associated with an increased incidence of infections, including urinary tract infections and viral infections, which was shown to be independent of potential confounders. So concluding, in CKD, universal screening of magnesium is not mandatory, but hypomagnesemia is common and frequently missed. So be liberal in screening for hypomagnesemia, at least in high-risk groups. And in kidney transplant, always check a baseline pre-transplant serum magnesium, because early post-transplant hypomagnesemia is universal and we have to monitor it. And ongoing periodic check, that is monthly for first 3 to 6 months, then individualizing, or when patient is symptomatic, and especially when patients have unexplained hypokalemia, hypocalcemia, arrhythmia, seizures, muscle cramps, or worsening glycemic status, do check the magnesium levels also. So I would like to highlight this point also, that SGLT2 inhibitor has an effect of increasing the magnesium levels after initiation. It can increase up to 0.12 to 0.36 milligram per deciliter, which is shown in studies also. And this is by decreased proximal sodium reabsorption, altering the gradient and increasing the magnesium reabsorption distally. And it has also shown increasing the activity of TRPM6. And coming on to the first slide of magnesium and sleep, magnesium deficiency can decrease melatonin, and normal magnesium can decrease cortisol, the stress hormone. And this was a randomized study I could find with 31 adults who had non-clinical insomnia symptoms, and they were given 1 gram per day of magnesium versus placebo. I couldn't find the baseline magnesium levels of these patients, but it was shown that there were significant improvements in sleep quality, mood, and activity outcomes, and non-significant improvement in insomnia symptoms and restorative sleep, that is refreshing quality of sleep. So this I would like to let it for discussion.